attention to the subscript numbers and take a look at the reference. We're not going to be able to obviously read every reference that they're talking about, but we're going to try to, sort of fact check also on that. Now, this one, the foreword, as you know, in a book is written by another person of somewhat of an endorsement, right? So I don't know this person, Dr. Henry Gremillion, I guess, Gremillion. He's a chair of a professor of orthodontics, and he's the director of their a group out there, Facial Pain, who obviously subscribes to a lot of the things that Dawson talks about, and I want to tell you that I appreciate this, but here's the thing that it will probably be helpful for you when you're reading this book. So this book, the copy that I have, the edition that I have, was copyrighted 2007. Okay, and this is actually a improved version of the first copy of similar book that I had from 1994, originally printed in 1994 and 1989. Because if you look at the very first page of this book, or the second page of this book, after functional occlusion, the cover page behind it, it gives you the sort of the copyright aspects of it. It talks about some materials previously published in evaluation, diagnosis, and treatment of occlusal problems. Copyrighted in 1989 and 1974. And the reason why I'm pointing that out to you is because you're going to realize many aspects of this book either repeat themselves or they have sort of different message. They don't necessarily contradict each other. So this book was written, different parts of this book, okay, was written over a long period of time. It's almost like the Bible, just because I'm more familiar with that. What I'm trying to say is, in the Bible, those of you who might have some Christian background, and I know that many of you have different religious background, and that's fine, okay? And I certainly have utmost respect for that. But, because I can speak more about that. There are 66 books on Protestant Bible, okay? Catholic and Protestant Bible, 66 books. Genesis, Exodus, and blah, 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 Matthews. That one book that we buy as one book was written over thousands of years. That's why there seems to be many contradictory aspects of that book. Why? Because the author, individual author who wrote that book, that chapter, okay, they come from different background. They've had different experiences. And they have different messages. The person who wrote the first book of Bible and the person who wrote the last book of Bible, they have very different audience in mind. They have very different life experiences. And even though this book is given credit to Pete Dawson, the book, as you can see now, was originally published in 1974, and he had kept adding on to it edition after edition after revision after revision. And the last book that I have was copyrighted in 2007. So this book is a cumulative result of 23 years of Pete Dawson's professional career. And I can share with you my perspective about occlusion, and what I try to emphasize has changed over my professional career as well. And that's the way it's supposed to be. We as professionals are supposed to evolve. We practice every day. When I finished my prosthodontic training, I thought I was a big shot. I thought I knew. And I'm gonna tell you that, um, so, I I was lucky enough that I started teaching right away. I don't know if that was luck or not. And then after a few years of teaching at UCLA, I've had enough of the UCLA bureaucracy. I left UCLA. I went into private practice. And then when I went into private practice, I realized, and no disrespect, it's not meant to be disrespect for academians, okay? But I realized, and this is, I did GPR. I did 1 year of associateship as a full-time general dentist. And then I went in and did pros. And then I came out and I taught the program. While I was teaching full-time at UCLA, I practiced in faculty practice, okay, on average, day and a half every week, okay? But when I went into private practice after 5 years of teaching at UCLA, okay, 6 years first time, 6 years, I realized, holy shit, private practice is much harder. It's much harder. You know why? Because your patient coming in are very wide range. They have different means to be able to afford. And guess what? They think it's a fair game to challenge what you say to them because they are speaking to just a dentist, not a professor. And you have to be able to, kind of like have them buy into what you're telling them and what you're doing for them. And your result has to be able to deliver that because I can't tell them, well, I know what I'm doing because I'm a professor. And so I'm going to say it took me about 8 years, 9 years in hindsight before I decided I know enough of what I'm talking about that I can tell people and start teaching people. Prior to that, I was just being a parrot. I was just repeating what I was taught. It took me about that many years for me to amalgamate what I learned and what my experience has been and say, this is my version of it. Okay? And all of you are going to go through that. What I really hope is that you're not just going to be repeating what you have learned. Right now, you're in that stage. That's okay. But eventually, you're going to be able to bring in your own knowledge and your experience and then be able to make sense out of it all together. Okay? And then the second part that I want to share with you on this and on this book about so first is this is a collection of Pete Dawson's thinking and his knowledge over a very long period of time. Okay, and then the second part that I want you to think about when you're reading this book is the opposite page. Okay, it says, as the years pass, the values that really matter come into sharper focus. It is to these great incentives in my life that I dedicate this work. And he says, to my God. And one might say, well, he's a man of faith. That's great and all that. And I agree. I mean, that that's great. I appreciate that. But, but I will say, and this is coming sincerely from a guy who at one time thought about going to seminary. Okay. Okay. So I will say to you that you have to think about where a lot of the current dental knowledge as it is taught throughout the world, okay, there's nothing wrong with it, but is Western culture centric. What I'm trying to say here is, even in the first chapter, he talks about it, and that is, to the Western culture, class 1 occlusion is the norm. And anything else that does not fit into that is malocclusion. It's just like when we talk about, we're going to talk about it later on, and I share with some of you at UCLA, we talk about our growth pattern, what is normally expected, this and that. All that basic science, as they are at least entered into most textbooks, were done by Caucasian doctors for Caucasian patients for Caucasian audience. And I'm not trying to get into ethnic conflict here, no. But what I'm just saying is that you need to keep that in mind as you are dealing with people with different ethnic background. It is not talking about the provider. I'm talking about the patients. Just as we're gonna, just as we're gonna be, how should I put it, individualizing it for their demographics, and sometimes, unfortunately, socioeconomics. Certainly, their dental IQ. We use that word a lot. Their intellectual capacity, their ability to understand and this and that, right? We have to think about their genetic makeup. Okay. And so what I wanted to say here is that, what was profoundly, okay, what was profoundly, what is it, striking to me when I first started reading literature in prosthodontics was how so many people in early prosthodontic literature cited God in their scientific work. Back then, that was the noble thing to do. Because if I were to limit my scientific understanding to biblical background or any of the holy books throughout the world, I'm going to say, how do I bring myself into flying on that airplane? We have to evolve. There is nothing wrong with God, believing in God and evolving, right? But what I'm trying to say is that let's try to separate that out. The bias, the bias that's built into it. I'm not trying to bring this into a secular discussion about beliefs, okay? But keep that in mind as we are looking at these writings from these people. They meant really, really, they certainly meant sincerity. They meant well, okay? But I want to try to get into the scientific background and what we can understand from these and for the patient at hand as we individualize them. Okay, so on the forward, first sentence, first paragraph, it says the form, function, and parafunction of the dynamic mascatory system comprises one of the most fascinating, basic, and important areas of study in dentistry. And there is just so much wrapped into that sentence. Okay, the form, function, and parafunction of the dynamic mascatory system. Okay, comprises one of the most fascinating, basic, and important areas of study in dentistry. Okay, it is the central theme of dentistry, and in order for us to understand and improve and have control over that aspect, we have to look at not only the function, we have to look at the form, and also have some understanding of parafunction, and recognize that it is a dynamic system. Okay, and we can talk about different meanings of that word, those words later on. Okay. And then I'm going to go on to read the explosion of technological and procedural advances coupled with improved materials and the general public's awareness of the importance of quality oral health and its role in quality overall, in role in quality overall health herald a new age in dentistry. Okay. Um, yeah. So I muted everybody. Okay, thank you, Ayman. Okay. So and that is so true. And I share with some of you here. But so after I retired from the UCLA in July, I was finally able to set aside some into digital dentistry. I have to admit, while I've been teaching at UCLA, because I spent so much time doing administration, I really didn't have time to understand digital or practice digital dentistry that much. Okay, I understood the concepts, but I was more of a shall we say a spectator. Okay, um, so one of the first things I did, as I now am in a private practitioner, is I went out and bought myself a milling machine. Okay, I I went out and so I bought a Glidewell system, not Derek, because I thought that was actually much more practical for me. And now I design many of my own crowns and mill, not only the final restoration, provisionals. There is a fairly decent steep learning curve, but if I can do it, anybody can do it. Certainly, all of you who are younger than me can do it much easier. And I can share with you, it definitely elevates my degree of my practice, just as I had expected. To be honest, you know why one of the insecurities that drove me to invest in that technology, $80,000. By the time I stocked all the stuff, $100,000 investment basically, okay, is you know, yes, what I can do with my hands is very, very important, but learning how to use this technology can make it not only easier for me, but definitively better result. You know, uh, as you know, I'm a big advocate of controlling my occlusion. I talk about approving every crown design if they are digitally made and all that. So that's one thing, obviously. But now I'm translating that to how I'm designing my own crowns. I can share with you that the other day I had a patient come back. I was doing number 24, single veneer, single veneer. I made the provisional with my milling machine with a composite material, and it turned out so much better than I expected. I said, fine, this is provisional. I kind of was doubtful the lab can do better, but I had to give them credit. And I wanted to initially mill it out with Emacs myself, but I go like, I'm not really sure about my ability to stain this and that and all that. And uh, and frankly, digital stuff is not as good as in some aspects as analog. And later on, we'll talk about that. But anyway, so I still sent the definitive restoration fabrication to the lab. They sent me the Emacs. Number one, the shade match was off. My provisional was better match. The contour was better with mine than the lab. So after talking to the patient for half an hour before I took off the provisional, and by the way, the provisional was cemented with bonding anyway, composite. The patient said, I just want to keep my provisional. Even though I did it as a provisional, I used definitive restorative material. And I said, you know what? As I continue to learn how to do my stuff, I'm going to make it And I can any day make it out with Emacs material. And if and when you're not happy with it, I can do that. Another day, I pulled number 2425, extracted. I made the patient a provisional for number 22 to 27. Again, I milled it from my Glidewell system. That one, I did it with temporary material because I knew I wasn't going to use that for my definitive. It took me a little while for me to design it. I had to get some technical support from Glidewell. But by the time I was done with it, patient was so happy, and I was able to make something. This is somebody who I was absolutely confident I can freehand any provisional. I can freehand an entire arch if I wanted to with ProTemp. Okay, and that's how I practiced for my last 30 years. Okay, and I would have my periodontist friends call me up and say, "Hey, Tom, I really want to tell you I like your provisionals and all this and that." And I'm here to tell you, no, that milling machine is much, much better. Not only does it look better, if I know what I'm doing, it functions better because I can touch up on the occlusion afterwards. Because milling does not get your occlusion perfect yet. Okay? All right? But I can control the tissue contour, I can control the crown contour, and if I need to, I can put my chairside addition onto it, and it's just so much better. It is really exciting to be able to learn new technology and merge into our understanding of dentistry. And I think you guys are really, really lucky to be living in that. I know that many of you are not in an environment yet for that, but as you know, move on in your profession, that's where the profession is going. Okay? And so when they talk about, and I think this book toward the end does talk about CAD/CAM technology. So it is, even though this book is, somewhat outdated, the basic concepts are still there in this book. Okay, so I wanted to just let you know, truly the explosion of technology is incredible, and I have to admit that then I kind of knew, but the response from my patients, and these are my patients who have been coming to me for years, right? But even then, when I told them what I was trying to do with the new technology infusion in my practice, every one of them gets impressed, and they validate my commitment to their best care. you know so I think that's I wanted to just share that with you. Okay, so the next sentence: additionally, the amalgamation of evolving science with the art of dentistry has fostered a true clinician scientist model of dental practice in the quest to provide complete dentistry for patients. And I want to say complete dentistry is not meant to be that you do everything, no, but it is meant to be complete as in something that you are willing to take over their overall well-being when it comes to dentistry. You are going to be the quarterback. You are going to be the team captain. Okay, I look at my patient every time I have to discuss new patients, especially. I tell them, as much as I'm interested in making sure that your initial concerns are addressed, what I'm really interested in is for you to look back 10, 20 years later and say, I did you good. Recently, and I don't do this too often, but recently I accepted an invitation from a couple of my patients, for dinner. And they're actually conveniently retired UCLA professors, so it's so we have more things to talk about besides just pleasantries. And why? Because one of that patient had been my patient for probably going about 28 years. almost 30 years. She was a patient of mine when I used to practice at faculty practice in the 90s. And for me to hear from her saying, Tom, I just want to tell you how much I appreciate what you have done for my teeth and my overall care all these years. And so to me, that's the best gratification that I had. And I can share with you, if it wasn't for occlusion guiding me, her mouth would have been a mess. It is a very difficult case overall. I just recently delivered number 6 implant crown for her. And now she's in her 80s, okay? And to carry that mouth going over, she's got mixture of natural dentition implants. My own work, some of them had to be redone after 10, 15, 20 years. Basically, I own that mouth. And that's what we mean by complete dentistry. So you want to have that perspective when you're looking at them. That single veneer crown on number 28, instead of me worrying about matching the contour and the shade, you know what many people would have done? They would have said, oh, let's just do 6 veneers. That makes it easier to match the shade and the contours. Okay. But if she were my sister, she and I are the same age, no, I don't want to do that. I educate the patient. She's been asking for that veneer because she has an endodontically treated tooth that's discolored. That's why we ended up doing it. Okay. She's been asking me for that for like last 10 years. And I kept delaying it. No, you really want to do it? Finally, when I did it, I felt like, I did her good. Okay. So if you have that kind of commitment, I can share with you, even in LA, people reciprocate. Even in LA. Okay? Further you are from in LA, further you're from LA, your patients will love you. Okay. So let's get back. Okay. The goal of complete dentistry the goals of complete dentistry include optimal oral health, anatomic harmony, functional harmony, orthopedic stability, and natural aesthetics. It is clear that to achieve these goals, today's dentist must become a physician of the masticatory system and beyond. Over the years, Dr. Dawson has advocated such a concept. Importantly, the key to predictable treatment outcomes that have been espoused in his prior works stress that enhanced form, aesthetics, does not have to come at the sacrifice of optimal function. In this book, he brings to the forefront basic principles of complete dentistry that can be applied to every dental discipline, regardless of the practitioner's level of education and experience. Okay. Diagnosis is the key to successful treatment outcomes. Unless one understands the system in health, it will be difficult at best to accurately recognize the pathology and to develop a case-specific, principle-centered plan of care. Now, some of you who have listened to me before, I've been saying that, especially when it comes to phonetic testing, because dental school does not really emphasize that. If you look at dental school or medical school curriculum, okay, we learn normal function first, as we have observed it. And then you learn pathology. The implication is that if you don't know, if you're not familiar enough with what is normal or the range of normalcy, how do you know what's pathologic? And oftentimes in dentistry, okay, people want to talk about how to improve, and yet they're not even good at defining pathology, let alone what should be considered normal or range of normal. They only want to enhance. They only talk about aesthetics. But you know what? Modern concept of aesthetics in dentistry, at least as it is advertised out there, actually caters to, I'm going to use this word, I had to make sure, because I looked this up, dysmorphia. That so many of our patients have distorted view of what they want to look like. Now, there's nothing wrong with doing that as long as you recognize that's what it is and patient recognizes it. That's okay. Okay? But let's not confuse that with, okay, with, what should be considered within normal limits and natural aesthetics. So these are the perspectives that I think is just as important for you to become a successful practitioner. That's why I wanted to have this book to read together, because these are the, sort of the editorial life's experiences that these many people share with us. And as you're trying to carve out your own sort of like niche as a professional, okay, I want you to have that perspective. I ask you to at least consider that perspective, because that's what's going to give you satisfaction later. I can look at my patients and absolutely be convinced that I care for them in the best way that I know how. Okay, and that the part of that, the beginning of that is, as this last sentence just says, diagnosis is the key to successful treatment outcomes. Okay, the next sentence that we already read that. So the following sentence, Dr. Dawson has done a masterful job of organizing the book in an easy to follow logical flow, beginning with the complete examination. Okay, blah, blah, blah. I'm going to skip that. The next paragraph, so this will be the third paragraph on the left side of the book. The sequelae related to adaptive occlusion are multifaceted. Compromise may occur at one or more of the occlusal interfaces, to include the tooth-to-tooth interface, the tooth-to-supporting structural interface, the neuromuscular interface, and or the temporomandibular joint interface. It is well understood that the primary manner in which orthopedic systems are comprised is due to mechanical stress or overload. Once disequilibrium develops in the masticatory system, the patient may develop one or more of a number of pathologic conditions representative of temporomandibular disorders. To develop an individualized treatment plan, the practitioner must be specific regarding the diagnosis, recognizing the TMJ represents a number of arthrogenous and myogenous conditions. The symptoms associated with these conditions frequently provide a complex diagnostic dilemma for the dentist and physician. Even when the causative factors are apparent, implementation of appropriate therapeutic measures may be difficult. Okay. Important additions to this text are the scheme for the classification of occlusion, a classification system for TMJ pathology, detailed discussion of myogenous form of TMD. Diagnosis, specific treatment based on detailed assessment of all aspects of the stomatognathing system. Recognition of other potential causes, comorbid conditions, maintaining factors as imaging of the TMJs in health and pathologic state. By providing these means of individualizing diagnosis, the reader is provided with important anatomic, physiologic, and neurologic perspectives that will certainly enhance problem-solving skills. Now, why is this Dr. Gramillion talking so much about orofacial pain, TMJ? You know why? Because that is so profoundly overlooked by such vast majority of dentists out there. And in a way, you guys are all so lucky. You know why? Because most of your colleagues are ignorant about this. Once you reasonably master this, you're going to be so much not only better in taking care of your patients, that's what's going to drive your practice going forward. And it just becomes naturally. Because so many people suffer. You know, one of the things that I really want to focus on here is this. The very first sentence of that paragraph. The sequelae related to maladaptive occlusion are multifaceted. Maladaptive. What I mean by that is when the occlusion starts to go off a little bit, because of our mascatory system being so adaptive, it automatically starts to try to adapt to it. That is why occlusal problems are so difficult to see by the clinician, because the patient is constantly adapting to it. But most of the times, it is maladaptive, meaning that adaptation may initially give some relief, but it is in the wrong direction. And that snowballs into bigger problems. And because most dentists, especially when you subscribe to different specialists, because they're only looking at small aspects of it, the patient is the one who is left holding the bag, himself or herself, because very few clinicians are looking at the comprehensive, complete picture. And all of us here are trying to be that person, that clinician who has the capacity to see that comprehensive, complete picture. Okay, and I'm hoping that this book will help us achieve that. And that's certainly what this book is trying to do. Okay. On the right side, third paragraph, a highlight of the book is a detailed discussion of cases representative of commonly presenting restorative challenges. Okay. Each of these is presented with detailed description of the problem list, appropriate diagnostics, and treatment considerations. Importantly, the potential pitfalls that might arise in the treatment of these cases are discussed. Post-operative care is delineated on a case-specific basis. Dr. Dawson has also provided objective measures that delineate specific criteria for success. Now, here's one thing here is this. Dr. Dawson once said, if you are going to quote me, date me. I don't think he meant, going on a date with him. Okay? All right? All right. So what I want to try to say is that what we want to do is our perspective on these cases, as much as our understanding, is going to evolve. patient's gonna evolve. Okay, that's our commitment as to how we get better. Okay, all right. So that's what I wanted to share with you from the forward. Okay, and then we're gonna get to preface. Okay, or preface, preface. Okay. There is a primary tenet that embraces the entire subject of occlusion from the TMJ to smile design. It is that the teeth are but one part of the masticatory system. It is absolutely true. Teeth are just one part of occlusion of masticatory system. Okay? And if the teeth are not in equilibrium with all the other parts of the system, total system, something is likely to break down. So even though we primarily work with teeth, and it is expressed through teeth, and it is going to be managed through teeth, you have to be thinking about the fact that teeth are only one part of the masticatory system. Okay? This means that to be a truly competent teeth doctor, one must be a masticatory system doctor. And this is what dental schools fail. Most dentists out there, I hate to say this, are one-tooth doctors. Even if they know how to do bridge, they're really one-tooth doctors. A patient comes in with a tooth that's either missing or about to be lost, they only think about replacing that space. You need to be able to zoom out and see the whole system, because the whole system most likely will tell you why they lost that tooth, unless it was because it was a result of a traumatic injury. Oftentimes, if you spend time learning about the diagnostic process, you can see it's like a movie. You can see how it got to that particular freeze frame when that event happens. Only by looking at the whole movie up to that point will you understand what that freeze frame is telling you. If you diagnose based on one freeze frame, you're really only treating the symptoms. Okay? Okay, I'm going to go down. Okay. No specialty in dentistry can be effectively practiced at the highest level of competence without an understanding of how the teeth related to the rest of the masticatory system, including the TMJ. A reader of this text should have the following expectations: a clear picture of how the masticatory system functions in maintainable harmony, a detailed understanding of how to tell what is wrong when any part of the system is not functioning in complete comfort and long-term stability, a specific process for developing a complete treatment plan for every type of occlusal disorder from the simplest to the most complex, an understandable proficiency in diagnosis and treatment of orofacial pain, including management of TMDs. Every dentist should know this. See how he emphasizes that. Every dentist should know this. And yet, majority of dentists don't know this in modern era. I think that's a fair statement. And in fact, specialists don't want you to know this. And I'm here to tell you, the most difficult discipline in dentistry is being the general dentist. Being a specialty is actually easier. Once you get into the program, you put the blinders on, you just look at it like this. It's so much easier, right? It is hard, much, much harder. okay, to be able to be responsible, to respond to the patient in so many different aspects of their oral care. Elimination of all guesswork in design of the most functional and aesthetically pleasing smiles, regardless of the initial starting condition. Reliable background information regarding how to analyze touted clinical concepts and procedures that violate principles of parafunctional harmony and that can lead to problems of instability, discomfort, dysfunction, or patient dissatisfaction. Dr. L.D. Pankey, and those of you who may not be familiar with him, Pankey is sort of like mentor to Dawson. Okay, Pankey Man, Schuyler. Those are the three guys that prosthodontists originally kind of followed to when it comes to occlusal concepts and beginning of the understanding of that. Okay, and there is actually still, I believe there's still a Pankey Institute. And these guys are mostly out of Florida for some reason. Okay, that's sort of like that's where they coalesce. Dawson is out of Florida too toward the end of his career. Okay, so L.D. Pankey wrote that only 2% of dentists ever reach the status of master. A master dentist can interview, diagnose, treatment plan, and motivate patients to proceed with a comprehensive treatment plan. But most important of all, he or she can execute the services needed with a very high level of predictive success. Those of you who have heard me lecture many times, you know that's what I always emphasize. Predictive, predictable. How do I anticipate what's going to happen? I can anticipate if I don't control all these things that it's going to fail. And sometimes with some patients, that's what I have to settle for. Okay. Now, I'm going to say in year 2025, I don't think even 2% of dentists reach this master dentist category. And I'm sorry to say that. In fact, I'm going to, I'm going to probably, somebody's going to shoot me for this. In fact, I think most prosthodontists don't reach this level. Why? Because so many people put the blinders on. They just want to do this. You have to open yourselves up. And you know what? In order to get there, we all have to be willing to be vulnerable. Meaning, we have to first accept, you know what? I need to learn. In order for you to say, I need to learn, you're basically implying, I don't know enough. And it's okay to say that. We don't have to be insecure about it. Okay. I'm going to go down to the next paragraph. The very last sentence on the last complete sentence on the left column, it says, the most prevalent misconception in the literature have been the discipline of occlusion and the relationship occlusion to the TMJs and oral facial pain. Unfortunately, it is still true. It is my goal to clarify those misconceptions and show dentists that there need not be a big mystery about the cause or treatment of TMDs. I so wholeheartedly agree. And let me tell you, I have never had the pleasure of meeting Dr. Dawson. But I've read a lot of his articles and paper and textbook. And he's so right about this. This mindset is absolutely required if one is to be successful in treating problems of occlusion, because all occlusal analysis starts at the TMJs. Now, here's one thing I want to tell you. I came to the same conclusion not because I had this attitude, I know everything. No. But because I learned the things that I learned over the years and through my training, And then having an open mind about what I'm seeing, the patients who come through the door. And when I treated them with everything that I knew, I come to the conclusion, I have no choice but to come to the conclusion that occlusion is indeed the central theme. It is not because I was indoctrinated. No. It was a very much of an objective conclusion that I came to. And I'm sure that's how Dr. Dawson came to that conclusion too, and his peers, the group that put together this book. Okay? So I'm not saying that it is absolutely required for you to go down this journey, but I would say that it is the inevitable conclusion of this journey that you come to, that they are intricately, you know what I mean, connected together. I have to look that up. Anyway, I've been talking too much this morning, right? You know that my brain is wired up too much now. Okay? Okay. So, not a single type of TMD cannot be understood and specifically classified today. It can be done by general practitioners, and it must be done by any dentist who aspires to the level of master dentist. In this age of aesthetic evolution and the extreme makeover, failure to relate smile design to the rest of the factors that control occlusal stability is an invitation to ultimate disharmony that can in time result in dysfunction and breakdown at the weakest part of the system. And I'm going to say aesthetic evolution and the extreme makeover includes utilization of implants. If anything, stakes are even higher. Okay? Most often, that weakest part is the teeth or the TMJ or both. Dentists who ignore the TMJs can never be competent in smile design or in diagnosing or treating occlusions. So, since many of you are recent grads, how many times when you were in dental school in your training did your clinician, did your faculty even mention the word TMJ when they are talking with you about restorative aspects of the patient? Okay. So you wonder why some cases have been unpredictable. Okay. So dentists who ignore occlusion can never be competent in diagnosing or treating problems of the TMJs. Dentists who ignore the relationship of the occlusion to the position and condition of the TMJs can only guess at diagnosing a myriad of problems that are seen in every general practice. Problems such as excessive tooth wear, sore teeth, fracture restoration, loose teeth, masticatory muscle pain, and a variety of other orofacial pain problems. By understanding what it takes to keep the total masticatory system in harmony has positive consequences beyond achieving the goal of peaceful neuromusculature. It is the absolute key to determining many of the most important decisions regarding aesthetics and tooth alignment, including the precise positioning and contour of anterior teeth. My goal is to take the guesswork out of everything the dental team must do to be successful in clinical practice. If you will study the pages that follow and commit the time-tested principles, you will determine the number one source of frustration and burnout in dental practice. Okay, what is the number one source of frustration and burnout in dental practice? A lack of predictability. What does that mean? That means I do something and I see it fail before my own eyes. That is lack of predictability. Of course, you can't help but become insecure then. Because while you're doing the next case, you're not sure if this is going to work. You do that year after year after year. It is not. I mean, actually, I was going to say, learning how to prep is only a small part of it. It starts with understanding of the mascatory system, and TMJ indeed is a very, very big part of it. Okay? It is easy to misinterpret clinical results because just believing systems may not mean a problem has been corrected. Let me read that again. It is easy to misinterpret clinical results because just believing symptoms may not mean a problem has been corrected. So you have to think about this. What we are really trying to correct is not the symptoms. Just because you correct the symptoms does not mean that you have control what's going on. And so teeth wear, bruxism, is a classic example of people trying to address the broken down teeth. And they give them whole mouth full of crowns and fillings and this and that. And they think they resolved it. All they did was they resolved the headache by giving them aspirin, Advil. They don't know where the headache came from. So if you give somebody crowns, whole bunch of crowns because their teeth are worn down, well, what makes you think those crowns are not going to wear down if you're lucky enough, if not break? You have to understand why it wore down that much. Right? And very few, if any, continuing education out there dare to talk about that cause. All they want to tell you is people come in with broken down teeth, they have worn down teeth, this is how I fix it. And this is why Dawson's message is so true. Okay? So, I want to basically stop at that point here. And then one thing that I want to say is that, I kind of forgot about this, but at the last sentence of his preface, it says, because this is written by Dawson, right? So one of the most notable results from this think tank environment is the formulation of specific measurable criteria for success. Chapter 47. I recommend an early reading of this chapter. It will enable you to start your study of this text with the end in mind. So, it's already 10:30, 10:40, 10:43. So I'm going to ask all of you to, let's take a little break time, right? So you know that when those of you who are familiar with me, when I start going, I just keep going, but then I get all burnt out at the end. So let's take about a 10-minute break time, okay? But I want to let you know that after chapter 1, I should have told you to just actually read chapter 1 and 47, but after chapter 1, I'd like you to read 47 before. I'm already giving you the next meeting reading assignment. And the reading assignment I'm going to try to always stay ahead. So reading assignment does not mean that we're committed to finish that up to that point on that session. because I guess that's one thing that I should clarify here. I hope to finish significant portion of this book within the 1 year. But from my own experience, I know this book actually takes more than 1 year in this once a month format. Like I said, this is like my fourth group that I'm doing this with this book. Okay. And that's okay. And as far as I'm concerned, that's okay. Because you know why? That means we had a lot of good discussion. That means many of you have brought on your cases. Okay. That means we had a lot of support here. The ultimate goal for every patient should be maintainable health for the total musculatory system. Maintainable. Another word, predictable. So what if you can do picture perfect work, reconstruction, if the stupid thing only lasts 1 week? You have to have a system that will be maintainable the way that you envision, that the way that you see. Okay? And that is the ultimate goal. I think everybody in the way I look at it is this: the money and effort that you may spend in advertising, if you spend that much more effort in providing predictable care for the patient, every one of your patient will become your advertising. And that's the best form of advertising, especially these days. I think contrary to all the social media, internet-based promotion, I think word of mouth or reviews are the best form of advertising. Not the fake ones, not the fake ones, not the ones that you purchase, but you can tell which ones are genuine. Okay, page 4 of the textbook. Oh, by the way, if you do have a question, you may want to give me a little hands up kind of thing, whatever. When I come to the completion of my thought process, I'll either try to answer your question or toward the end of that section, okay, so that our train of thought is not broken up, okay, and in that process, okay. But I do definitely encourage you to don't let go of your questions too long, okay. Okay, so the first chapter on the chapter 4, I'm sorry, page 4 on the left hand column, under the philosophy that underlies an honest concern for patients can be summarized in one word: complete. Embracing the concept of complete dentistry always puts the patient first. It says that every patient is entitled to a complete examination and a clear understanding of every problem that should be treated. It recognizes that almost every dental disorder is, in all probability, a progressive disorder that will cause increased problems if not detected and treated in a reasonable time frame. That's another way to say what I said right before our break, and that is, you need to look at the movie of how it got to that still frame. It's a progressive disorder. Our patient's mouth gives us a warning sign, okay, over time. And earlier you can detect it, you can figure out how to provide care for that, okay, in a hopefully least complicated manner. Like, for example, this morning actually I had a patient who called me, and left me a message, and so in this break time I reached out to him. Somebody who had been my patient for probably actually 30 years. No, not 30 years, 20 years. 20 years. Okay. As a relatively young guy, maybe in his 40s. I gave him a treatment plan to make his back teeth a little taller. Why? Because I saw his front teeth banging too hard, wearing down, and his back teeth, composites, a lot of composites, wearing down, and his front teeth were touching too much. And I have already provided him a splint therapy night guard. He loves it. It's probably carried him over many, many years all this time. And I told him, I know this is kind of you don't have any blaring sign that things are wrong, but this is what I see coming down the road. And after I got to know him a little bit, he bought enough of it so he got himself a night guard. But that's only gonna be able to slow down so much because he keeps losing his vertical support in the posteriors because of large composite restorations. Okay. And so I gave him the treatment plan for some crowns and some composites in the back. Not a full mouth rehab. I don't need to do that. Um, and then he said he can't afford it. It's like, okay. So then I told him, okay, then you know what? Maybe we should consider doing composites to raise your bite a little bit. However, I had to tell him, once we do composites, that means you're making a commitment to go to crown because these composites will not last that long. My experience has been that posterior composites, um, if I raise somebody's video with only composites, it will give me about 2 to 3 years at most. This is with them wearing night guard. Okay. Anyway, he wasn't really buying it or whatever. And he continues to come to my office, but he never really delved into it. And I wasn't really gonna push him because once I do the composite, what I don't want is to do composite refurbishing every 2 3 years for the rest of his life. Because at some point, composite baked onto another layer of composite, what happens? They start popping off much easier. And I don't want to remove composite every time I do the whole thing, the whole composite, because that creates more work than what it's worth for me. As much as I care for my patients and I want to provide them the best my know-how, I'm certainly not going to paint myself into a corner where I can only treat one patient a day and I get paid for only composites. Okay. And so what happens after 20 some years? Now it's breaking down his teeth. So he was having, fracture lines to the point where he was beginning to be sensitive on the tooth number 18 a few weeks ago. So I told him, I said, look, this is now beginning to happen. And I was reluctant, but he says he can't afford anything more. So I started prepping his crown, number 18. And guess what? I can't grind enough on number 18. Given the vertical dimension he's at now. So I said, no, we really need to raise your bite. And now those of you who are new to me, I said, I've already done phonetic testing on you. You can probably tolerate 1 to 2 millimeters in the molar thickness, which means I really don't have to grind that much occlusion too much. But he says he can, whatever. To make the long story short, I provided as much as I could, and I said, I don't really want to proceed on this. You have a provisional. I really want you to think about this. And he comes back and says, okay, Dr. Lee, I'm going to do it, but it's really hard for me on my cost factor. Okay. And so we sort of like agreed to maybe do a few teeth here and there and whatever. Today he left me a message this morning saying his temporary popped out. Didn't break, it popped out. So to me, here is the thing, I feel confident with my temporaries. Now that was my handmade temporary, not milled. But if my temporaries are popping out unpredictably, that means his occlusion is not in control. Okay, so that's what I mean about progressive. You know. Now here's one more thing you need to know. Most dental insurance companies, their policies will say if you ever do any restoration for the purpose of improving their bite, changing their bite, according to their terminology, that is not a benefit for dental insurance. So be careful when you write the narratives to the insurance company. If you tell them I replaced number 18 because 18 was in bad occlusion and I wanted to improve the occlusion, and the radiograph essentially doesn't have any usual breakdown that's associated, whatever, the insurance company would love to reject it for you. So I have to play this insurance game with the company for the patient's benefit. I can do what I need to do because of my experience and what I know. Okay, so basically, what I'm gonna do with him is I am gonna have him in writing. We're gonna do 1 or 2 crowns at a year for his insurance benefit, and the others are gonna be composites that we're gonna do. But we're gonna make a plan to do 1 to 2 crowns a year that I think I can push through the insurance one at a time. You know that insurance company, they are looking out for any excuse not to pay for somebody's benefits. If I send them a treatment plan or a claim for, 4 crowns, 18, 19, 30, and 31 at the same time, and they look at the radiograph and there is no decay, they all just have composites on it, they're just going to say no. And it is extremely hard for me to tell them they all have same level of crack lines, fracture lines that cause me to do crowns on them. No. So what I have to do is I have to play that game. But knowing knowing the fact that he is committed to wearing a night guard already, that he has demonstrated, okay, and knowing what I know, that I don't mind doing composites for one time, which I'm going to charge to the insurance. Okay, those are things that we can do if you know how predictable your work can be. And those of you know that if I were to charge my patient for a composite on number 18, if I charge for a crown next year, 18, insurance will take out their benefit for that composite. Most insurance will pay for the crown at that point, but they will deduct that composite payment that they had sent out. They usually will be in effect for 2 years. Okay. And what I tell my patient is I'm willing to, work with them so that, patient doesn't have to pay for it twice per se. But there is going to be some sort of a compensation between you and the patient for what you're doing because patient couldn't afford it. But ultimately, that's what your goal is. Okay. So the third paragraph, the first sentence, it is axiomatic that patients cannot perceive a need for treatment if they do not clearly understand what problems are present. That is the primary purpose of the complete examination. But think about this. Patients cannot make a truly informed decision about treatment unless they also understand the implications of not treating such problem within a reasonable time frame. Practitioners cannot reliably predict implications if they don't have a working knowledge of the total masticatory system, which includes the inner relationships of the teeth, TMJs, muscles, and supporting tissues, in addition to a clear picture of the causes and effects of occlusal disease. So they all go hand in hand. If you want your patient to buy into what you're proposing, you need to be able to explain it well. You need to be able to look into the future. You need to be able to look back into the past that patient can relate to. You need to be able to share with them what your findings are of that patient's mouth. And you might say, oh, those patients who ask a lot of questions, they're a pain in the ass. That's true. But at the same time, majority of those patients who ask a lot of questions, majority of them, if you can satisfy their curiosity, they become better patients. Not all of them, but majority of them. Okay? So it is really our responsibility to be able to learn enough about this that we can explain to them what had happened to them until now, not just their condition today, but what had happened to them until now, and then help them project into the future what's going to happen if we don't do anything. Not as a threat, but as an anticipation of future. Then they are properly equipped to make an informed decision. And in order to do that, not only you need to know that have the knowledge, but you need to be willing to do reasonably comprehensive examination. Next subtopic, examination with an implication mindset. A key question in every complete dental examination is fundamental to the integrity of the doctor-patient relationship. Are all the components of the masticatory system maintainably healthy? Maintainably healthy. Is it going to be predictable? This requires analysis to determine the implications of not treating any parts that are disordered or diseased. Answering these questions is the foundational basis for the complete examination. It is also the guiding principle for formulating what treatment plan should be started, what could be deferred, and what may not be required to save teeth but might be desired for improved aesthetics. Understanding the short and long-term implications of each type of dental disorder is the basis of establishing priorities of treatment and is the essential information that is used to establish phased treatment for patients who cannot proceed right away with an extensive treatment plan in its entirety. It is rare that a patient can accept complete treatment plan that the dental school taught you to do. Dental school teaches you to do comprehensive exam and then write up a comprehensive treatment plan and then expect your patient to accept that. The reality is many of our patients cannot accept that. It does not mean we're supposed to abandon that, no. But you have to have enough knowledge and confidence and competence to be able to break it into phases that the patient is able to partake in. Now, no matter how much you try, there are some patients who just won't be able to do that, or they refuse to do that. Well, in those cases, early divorce is better than having, spend 100 years together and then come to that conclusion. Or rather break up before that you tie the knot. I guess that's the way I should put it. Okay? It says types of implications. Every dentist needs to develop a clear picture of what a stable, maintainably healthy masticatory system looks like. Now, in order for me to phase it out, I need to be able to have reasonable predictability at each phase, not only at the end, each phase. Okay? Every dentist needs to develop a clear picture of what is a stable, maintainable, healthy musculatory system. So in your mind, you need to have a certain goal for each phase that will satisfy your goal of having predictability. Now, one of the things that you need to keep in mind, at least in America, and I'd imagine most developed countries throughout the world, is this. No matter how much discount you give them, if you treat them in your office, then you're wholly responsible. Your liability does not get reduced by 50% because you give them 50% discount. So just because you're cheap does not lessen your legal liability. Okay. Now, if you want to be able to give away pro bono, as in like free work, I'm not even sure if even if you do not charge anybody, if the patient anything, even if you do it completely free, if the work was done in your office as part of your business operation, even if you didn't charge them, I don't think you can get away with legal liability. The only time that Good Samaritan law works is in that particular situation. If you either volunteer at a place where it is known that you are working for another institution where they're expressly, donated work, okay? You need to keep that in mind. The legal implication, even if you are doing the patient a favor by splitting, and that's why it is heavy on me whenever I try to accommodate my patient to go out of deviate from the norm to accommodate their situation. It is that much more requirement on my part. Okay. In complete examination, each part of the system should be analyzed to see if there are any signs or symptoms that indicate disease, disorder, or dysfunction. If any departure from health is noted in any structure, the key to both diagnosis and treatment recommendations will be directly related to the implications of not treating that disorder in a timely manner. There is that immediate implication, deferred implication, and implications for optional treatment. Okay. So you need to pay attention to all those different aspects of that. Okay. And I'm sure you can understand what those are for that. Okay. I wanted to get to at least the next part before we wrap up on our review of the book. The goals for complete dentistry. The goals. Okay. Okay. A dental examination is complete if it identifies all factors that are capable of causing or contributing to deterioration of oral health or function. It is incomplete if it does not expose every sign of active deterioration within the musculatory system. A complete examination does not rely solely on symptoms because signs almost always precede symptoms. That's what I've been saying. A complete examination does not rely solely on symptoms because signs almost always precede symptoms. You, as a doctor, even if the patient is not able to tell you what the problems are, by looking at, examining, and listening to the words that the patient is using, to understand where the signs are coming from of the eventual breakdown, the direction at which the patient's headed. If you only know how to treat obvious symptoms, anybody can do that. Okay. Okay, the bottom of that paragraph. 7 specific goals should be the objective for patient care. Freedom from all diseases in all musculatory system structures, maintainably healthy periodontium, stable TMJs, stable occlusion, maintainably healthy teeth, comfortable function, optimum aesthetics. And he sneaks it in there, periodontium. In order for you to be a good restorative dentist, you have to respect and become fairly good at understanding periodontal conditions. Okay? Okay, so I'm going to jump to page 5 on the left-hand column, third paragraph. Okay, it starts with, in the analysis of any oral diagnosis, each of the above goals should be evaluated for fulfillment. This evaluation will fall short unless the reasons for form and function relationships are understood along the cause and effect nature of health versus disease. This type of analysis eliminates dependency on empiric treatment or making patients fit averages. There are many stable, healthy dentitions that do not fit the averages, that are not class 1 occlusion, and that violate customary guidelines for normalcy. Attempt to correct these dentitions often end in failure. An existing harmony of forms and function may be disturbed by the treatment. Such mistakes can be prevented, and a high degree of established predictability can be developed if the goals of treatment are based on a foundation of why rather than how. And, earlier I was talking about that, right? Not everybody needs to become class 1. Okay? And there's plenty of malocclusion within class 1 occlusion. And there are good, predictable, stable occlusion in class 2 and class 3. Okay? Do not let your own bias get in the way. And it's unfortunate, almost every orthodontist has a bias where they want everybody to become class 1. Class 1 is optimal. There's no doubt about that. Okay? But there are a lot of other physical characteristics that will say that is optimal that many people, if they don't have it, they don't do anything about. And we have to let that be known to ourselves and to the patient. Next paragraph. Okay. There is an understandable reason for every position, contour, and alignment of every part of the netostomatic system. There is always a reason for every incisal edge position, every labial contour, every lingual contour, and every cusp tip position. There is always a reason why some teeth get loose and others wear away. There is a reason why TMJs hurt, why masticatory muscles become tender, and why teeth get sensitive. There is a reason why certain occlusion remain stable and others do not. Treating the effect without treating the cause is rarely a satisfactory outcome and is almost never necessary. Okay. The next paragraph, about halfway down, the last sentence of that left-hand column, the fourth line from the bottom all the way to the right, total elimination of all causative factors to the point of complete reversal of deterioration is not always possible. The problem of some patients are too severe or have gone on too long to expect a complete return to normal, to ideal health. But the degree to which we can eliminate the causes of deterioration will directly relate to our degree of success in changing unhealthy mouth to healthy one. Now, I am going to stop right here for today's discussion, because once we get into causes of deterioration, then it just is a continuation of the several topics for the rest of the chapter. And I'm going to put a little bookmark there right now. And I am going to ask all of you to read that section again on your own before our next session, because now we're getting into more specifics of dentistry.